Welcome to Fuzzybutts and Friends. Well, as much as it drives Fuzzybutts all over this place absolutely crazy when they hear me say it, I am the host of the show, your big dog, Luke Robinson, and we're happy to have back with us week again Ginger Morgan. She's the executive director of the Puppy Up Foundation. Ginger, how are you?
I'm doing well, and you just can't get rid of me, can you? I just keep coming back week after week after week.
You are well. I'll give you a little bit of job security, but you never know. Also, there's always the monkey wrench that is life. You never know.
Okay, so you let me come back.
Where
So
did
you let
Lolly
me
go?
come back.
Where did Lolly go? You had Lolly on your lap a little while
He
ago.
left me.
Ah,
Dogs are fickle that way.
especially female dogs, female fuzzy butts, in my experience. That's why I only have the male type. Well,
Uh-huh.
as much as I'd like to banter with you for a while, this is season 2 of Fuzzy Butts and Friends. We just started that up. And as we launch all brand new episodes every single week on our YouTube channel, that's fuzzybutstudios.com, or you can listen to Fuzzy Butts and Friends on your podcast platform. As much as we have new content coming to you every week, we're bringing something back this week. I think that's a little bit old, Ginger. We have somebody we've known for quite a bit of time, and so I consider her an old friend. She's Dr. Debbie Knapp. She's with Purdue University. She was also the recipient of one of the Puppy Up studies, clinical trials we did.
Yes.
Yes, absolutely. We got lots to talk about. Dr. Knapp, how are you? Welcome to Fuzzy Butts and Friends.
I'm doing fine, thank you, and appreciate the chance to join in the conversation today.
Yeah, absolutely. We've had many conversations in the past, and we have lots to talk about. But before we begin, Happy New Year to you. Did you have a nice holiday?
Oh, it was great, thank you.
Good.
Could have been a little longer, but it was good, yes.
It can always be longer. I'm the guy that has a ton of projects, so as long as I can spread those holidays out, the better. We like to begin the show with everyone's origin story. But before we do that, your Fuzzy Butts. I know you're there. Are you at home, or are you're there at Purdue University?
I'm in my office.
Your office. I thought that was the case. So tell us about, do you have Fuzzy Butts?
I have a wonderful little yellow lab named Addie.
Addie.
I mean, she's small as labs go, but she's awesome. She's super friendly. Loves to play ball more than any dog I've ever owned in my life. She will retrieve until she just about falls over. She's wonderful. So yeah, she's great.
I had a retrieving dachshund once, and she likes to retrieve the balls so much that when my nephew put the tennis ball on top of the refrigerator, she licked the enamel off of the refrigerator, thinking that she was going to get to the ball.
Well, I have to admit, when my dog was a puppy and we were coming back from a place to play ball in the car, and she dropped her ball on the floor, she was so anxious to get to it. She did eat a hole in the car seat trying to get to where her ball was. So,
oh no.
Yeah, but anyway, she's great. We love her.
That's a great story and a visual too. She can't be with you for this episode. Well, tell us, Dr. Knapp, about your origin story. How did you get into veterinary medicine? Sounds like you're a lover of Fuzzy Butts, so I'm sure that's probably how you got your start. And then also, more importantly, oncology.
Well, let me think. Like a lot of people, when I was 12 years old, and we were all asked at school to make a decision on what type of career we were going to have, I couldn't think of anything better than veterinary medicine. It was so fascinating, and I had the chance to go to a small animal clinic where my dad was the accountant, and got to know the practitioner there, wonderful man named Tommy Needham. And I started working as soon as I was legally allowed to work, and worked up through the kennel and then as an assistant. And he was just an awesome mentor. So I was very fortunate to get into veterinary school and get the DVM degree. And I was in practice for a couple of years after that, and really liked certain parts of it, but decided I also found the really in-depth, complicated cases perhaps the most fascinating. And I decided I would become an internist. So I was fortunate enough to get a residency, but my residency was half medicine, half oncology. And I'd only been in the residency a few weeks and realized oncology was where I wanted to go. There was just so much potential for progress. It was so interesting. And one of the things that really attracted me was to be able to do work that helps dogs and that in many instances can translate into helping people. So I went down that path and have never looked back.
Wow, that's quite an origin story. But you know, yes, a lot of people start out early in life with that dream and that vision, but it's rare the person that takes it all the way as far as you have, though, right?
Well, it was, I
Well, I
wish
know that it was kind of a loaded question. I know
yeah, I wish I
that.
could, yeah, I wish I could tell you I was brilliant and I planned it all out, but that's not how it happened at all. I went from one step to the next and kept having the chance to build on what we started and was fortunate. Actually, one of the things I did after my residency going into it, I didn't know it would be as meaningful, but I spent 2 years in a cancer pharmacology lab and was classified as a postdoc. And to pay my salary, I had to teach veterinary toxicology. And it was great. I taught myself and then taught the students. And and then a position opened at Purdue, and I was again fortunate enough to get that. And just really, it's just been a great experience. I have the chance to do all three missions here. I teach, I work in the clinics, and I get to do research. So it's great.
That's the trifecta. But it
Right.
was kind of a loaded question, though, because there are only 500 or so veterinary oncologists in this country. So statistically, there aren't very many people that could have taken your path. But it is a great origin story. It's wonderful. And that was the next question I was going to ask you, is that if you are a practicing clinician as well, but you just said that. So do you like treating patients? Is that something you're passionate about as well?
Oh yeah.
I guess my question is, are you as passionate about dealing with pet parents and treating patients as you are about the research end?
I think I'm honestly passionate about all of it. That's probably a cop-out answer. I will say that the work I do in the clinics has changed, evolved tremendously over the years, and not in a way again that I expected, and not in a way I was smart enough to plan. But we've had a focus in urinary bladder cancer for several years, and that pretty much is almost all I do in the clinics now. Um, so I'm in the clinic certain days every week, and pretty much all of my patients are those that have bladder cancer or that were thought to have bladder cancer, and I still find working with the animals and interacting with the owners to be very rewarding. Um, I I wouldn't be happy if I didn't have the chance to do the other things as well. I really think I need all three of those activities. Of course, a lot of times it's like having three full-time jobs, but
Yeah,
you
I can
figure out
imagine.
you figure out how to make it work. So
Absolutely. Well, some of my favorites, and I believe that are the best in the world of veterinary oncology, all are the same. I think of Phil Bergman that runs
yeah,
clinical trials for the BCA, Craig Clifford, who now
right.
has ascended the ranks at Blue Pearl. But both of them are passionate practitioners. Both of
Yeah,
them love being with
yeah,
pet parents and their patients, and both of them have a tremendous bedside manner as well. I
sure.
don't think I've ever seen you in the clinical setting, but I can only assume that you do well. But I believe it's important, though, Dr. Knapp, and I'm glad that we're speaking about this, because you can get yourself so immersed in the research and lose the human side of it, or
Right,
the animal
right,
companion side of it. And that's when things get scary, where it
right.
becomes too scientific, because we see when science loses its humanity. We've seen that in the last couple of years, and I feel like it's probably going to only get worse. So I
Yeah.
think it's a great thing, and it's a great conversation, and that you teach as well, because that too as well is an important part of it. So, like I said, the trifecta, that is what you
Yeah, I
are.
think the other reason I still think it's really important to be in clinics is that's where you see what are the most pressing problems? Like what do you need to achieve in your research that's really going to matter? And so I don't want to lose that. And I even take it further than that, in that I try to stay abreast of human cancer medicine, especially bladder cancer, because that's our focus. And so I have the chance to work with MD medical oncologists and urologists and go to human meetings, and that also is just it really helps you focus your research efforts into what do we really need to do. You don't always accomplish it, but at least it knows what you're trying to get done.
That was perfectly said, and a perfect segue to what I wanted to talk about next when you said pressing problems. What are, Dr. Knapp, the pressing problems that you're seeing right now at the clinical level as it pertains to cancer as a whole, the whole population of cancer? But I know that you just said that you most nearly all of your patients are bladder cancer.
Drink of water.
Sure, absolutely.
Starting to get a tickle in my throat.
Take a second. No problem at all. So what I was saying is that you were talking about the reason why you love being in the clinical setting is that you can see the pressing problems that are pertinent today as of this moment. And I absolutely love that. And it's a segue into what I wanted to talk about next, Dr. Knapp, is that what are you seeing? I know that most of your patients are bladder cancer patients, but think about maybe the last 10 years. What are you seeing as the pressing problems right now in cancer as the general population community of cancer? And also start off with that, and then we'll get into bladder cancer next.
I think in veterinary medicine in general, we're obviously all stressed by not having enough veterinarians. So there's a shortage of veterinarians, and I all across the country that I know of, there are long wait times to get in. We try to do the best we can to fit people in, but it's a challenge. I think that's one thing that we need to address. The other challenges in the oncology world, particularly, I guess I could think of a couple. I would really love to see us be able to shift at least part of our clinical focus into efforts to prevent cancer. And I do think there has been movement in that area, but I think we need to do a lot more. We had the chance to just complete a bladder cancer screening study. And I know we're not on bladder cancer, but it totally opened my eyes to what you can accomplish when you find cancer early. Using a fairly conservative treatment, we were seeing remission rates twice what they would be in animals that walk in our door, not because we screen them, but because they're already sick. So I think there are several areas where we could do more in prevention. I think that's something, I wouldn't call it a problem. I call it an opportunity. It's an opportunity to do more. I do think one of the challenges we are facing is there's more and more products that are being put forward to pet owners and to veterinarians that I wish there were more rigorous studies to back them up before they came our way. So I think we need to keep insisting on good science in diagnostics, therapies, pretty much everything. So I think, it's a challenge to have enough people doing really rigorous research, getting that research out there. And I think we just need to proceed cautiously and really ask at each juncture, what do we really know? And do we know enough to go down this path or not? And I don't mean that to be critical. It's just, there are a lot of opportunities out there to do really good science. And then there are opportunities where good science is sort of not followed as much as I'd like for it to be. Does that make sense?
Absolutely.
It does, yeah.
Absolutely. There certainly is not nearly enough funding out there, but that's
well, sure. That's always, that's always
the case.
That's always an issue. Yeah.
Well, I mean, I read the announcement that the NIH NCI, I think is going to invest $20 million, but I'm thinking I've been doing this for 15 years, and that's $20 million a little too late for me. I mean, that's great, but that's only a couple of studies, or I don't know how that's going to be portioned out. But I'm more of a critic, and this is not really where I wanted to take the conversation right now, talking about these very high level questions. But while we're here, I do want to explore them. Let's go to the shortage of the veterinary oncologists first, because that is a huge problem. And I, as a pet parent, and pet parents all across this country suffer from it because they have to travel hours and hours and hours. And fortunately, some of them don't have the economic resources to do so. And so they opt not to do that. And so, this is not making a statement on general practitioners, but sometimes they're not the best. And sometimes they don't get all the right or current data to make the best medical decisions on behalf of the companion animals. And it's a big, big problem. And I've talked to about that issue with Phil Bergman and Craig Clifford. Phil, in particular, I wanted to mention this. He as you know, he was recently diagnosed with bladder cancer. And we were talking about, and he said, the average wait time now for dogs, I think for a cancer visit with board certified veterinary oncologist is about 3 months. And he said, my wait time to see my oncologist was 3 months as well. So I don't think it's reasonable. Yeah, but I didn't think, because I'm in love with Phil. And I'm probably was awe-inspired by everything he has to say. But I didn't think about that and say, but that's not actually right. 3 months to a dog being diagnosed with cancer is a lot longer than 3 months to humans. So in my world, again, coming from the pet parent world, 3 month wait time is unacceptable. We have to do better. And only having a population of 500 or something board certified veterinary oncologists in this country is a problem. And when I spoke to Craig, it's a logistical problem that I don't think is a big priority. And it's something that I'm going to be talking about more and more to veterinary oncologists, because I know there are a lot of pet parents out there that are suffering, and it's from lack of access. And it's a logistics problem that can be solved with all the great veterinary oncologists within your community. I wanted to mention that before we moved on. And then I want to mention something you said about screening that also dovetails into that, which is also really important, because I didn't want to leave that as well. Because going back to 3 months in the cancer world, the canine cancer, as you know, can progress substantially with that time frame. So there are good tools out there. PetDX we've had on our podcast. I'm not sure if you know that they're Onco9, but the great thing is there are some more tools. But what I was asking you, didn't mean to get long-winded there, but I didn't want to lose those points before I moved on. I want to go ahead and check those off. But what I was speaking about is more in a broader sense, is that what are you seeing in terms of cancer at the clinical level? Are you seeing new types of cancer? How are your successes how are your outcomes by using the best and greatest tools out there? Just kind of give the audience of what you're seeing with all the cases of cancer. And we can go ahead and talk about bladder cancer if you'd like to just focus on that right now.
Well, and actually, before I get to that, could I circle back on a couple other things?
Absolutely.
I am tremendously excited about the funding coming from the National Cancer Institute. It's elevating veterinary oncology as a field that will help animals and help people like we have never had before. And so I am all for it, and I'm very, very grateful that the leadership in NCI has seen this as a priority and they're putting funds there. So that's just my quick 2 cents worth about that.
No, I think that's
a win.
That's very important. And it's very important that they're doing that. And I didn't mean to be dismissive, but you're talking to a pet parent who's lost 3 dogs to cancer. I've been doing this for 15 years. And this has been a grind. It's been a Sisyphean task from day one that I never thought it would take us this long. And so any funding is great. But 20 million, as you know, that doesn't stretch, that doesn't cover a lot of canvas. We have a lot of important research that needs to be done out there. And as you said earlier so perfectly, is that we're definitely not doing enough in prevention. And as you know, I think it's 90% of all NIH funded grants, I think the last statistic I read, are in treatment, not prevention, which means only 10% of funding goes to prevention. So clearly, if you think, well, let's make prevention a bigger piece of the pie, then that $20 million gets spent very quickly. So I only say that as a pet parent who lives in constant frustration. So I don't mean to be dismissive at all.
No.
It's a wonderful thing, and it's a wonderful thing for the community as well.
And I do think the pendulum is swinging more toward prevention. I do. And the other thing I'll mention that the NCI has done, that there's been a large investment in it, but it's something that will help all of us indefinitely. And they've established a data commons. It's called the Canine Integrated Data Commons, or Integrated Canine Data Commons. And it's a place to deposit all kinds of data, sequencing data, path data, images, treatment response, pharmacokinetics, everything. And And I think the last I heard, there was something like over 30 terabytes of data in there, and it's open access to anybody in the world that wants
Wow.
to study that data. And it's very cool. I won't take up a lot of the time right now
But
describing all the nuances.
no, I want to nerd out with you. I don't want to leave
Okay.
this because this could be a potential episode for Fuzzybutts and Friends. I'm very fascinated with this. So it's the NIH Canine Data Commons. Is that what you said?
It's called the Integrated Canine Data Commons, ICDC.
Data Commons. Okay. And so, but it's not limited just to cancer and the canine.
It is cancer. It is
It's
cancer in
cancer.
dogs. That's what it's limited to. It
Wow.
may expand in the future, but right now it's cancer in dogs.
And it's accessible to me and even to Ginger.
Yep.
Ginger probably won't be reading it.
Yep, that's right.
So that's awesome.
Anyway, I sort of I got away from your question about actually, can you think what the question was now?
We do this often between ourselves.
Okay.
Yeah, no, and also this is very organic. Our show is. I don't want to go by
Okay.
bullet point by bullet point. It's very fluid, and I like to keep it that way.
Okay, you were asking about the outlook for dogs with cancer, I think, and how have things changed?
Sure, I
How have
just
they
kind of
changed?
wanted your
Okay.
general idea of how cancer is right now and how's it changed while you've been a practitioner.
I think that one of the things that we have really improved upon is to, in many instances, understand it's a chronic disease that we're going to manage, we're going to maintain quality of life, and that we aren't going to go to exorbitant measures to, I guess, say cure at all cost. I think we've gotten smarter about realizing that there are many, many animals with cancer where we can make them feel good, keep them feeling good, buy them quality of life, but understand that we're not going to cure them. And so we want to get to the point where we either aren't seeing them because we prevent it or where we can cure them. But I think where we've really made progress, and I've told our residents this, and then I say, right after the dinosaurs died and I got into oncology, but when in my residency, we were trained that you really had to shrink the cancer dramatically, preferably make it go away, but at least have dramatic shrink to be called a success. And now we realize, hey, if the dog feels good and we can keep their cancer from growing, they'll keep feeling good. And that's a good outcome as well. So I think we've gotten a lot better there. And I think we are really poised to push improved outcomes in a few areas. One is immunotherapy, which is, just about to explode. Another is targeted drugs. Another one is trying to figure out how the cancer in the specific individual is going to behave, and what can we do to understand how to best treat each individual. And then the fourth area is screening. And I think we've set the stage to really make progress on all four of those fronts. And that's going to improve upon what we can do now.
Absolutely. I didn't mention before that you are a medical oncologist, right? So you see this through the lens of a medical oncologist.
Right. I am very biased that way. Yes.
All of them are. That's exactly what I was going to say. You talk to a surgical oncologist about how they would approach a case.
Right.
It's entirely different how medical different. But so I think that's important for the audience as you're looking through that lens. But you're right. All of those are exciting potential technological developments on the that are up and coming in the future. Let's focus now specifically on bladder cancer, because that's your area of expertise, and that was one of the studies that we funded. Right. So how did you get into bladder cancer? Why that in particular fascinates you?
I wouldn't say it's quite an accident, but it wasn't in my plans as I started moving through into my oncology residency. What happened, which I still look back and think, wow, I didn't realize at the time how important that was. But before I graduated from veterinary school, I had two dear dogs. They're family dogs. We love them very much. And they both developed really severe advanced cancer. And for one of them had a soft tissue sarcoma that had eaten through 3 ribs. The other one had a carcinoma unknown primary that had metastasized widely to the lungs. And both of them were really compromised by their cancer. And at that time, there was no known treatment for either of their cancers. So when the first one developed cancer, we started treating the dog with a non-steroidal anti-inflammatory drug. We just wanted to make the dog comfortable. And much to our surprise, the cancer regressed substantially. We weren't expecting that. We didn't, at the time, it's weird. I didn't realize how important that was. I thought, oh, well, maybe cancer just happens to go away. I didn't realize how special that was. And so now I do, of course. And then, so one dog developed cancer first and the other developed cancer, and there was no known treatment. And we said, okay, let's just put him on this drug and keep him comfortable. And his cancer also regressed. And that dog had actually complete remission and had a necropsy and was cancer free. So that sent me down the whole pathway of studying the anti-tumor effects of non-steroidal anti-inflammatory drugs. So I came to Purdue, and after having to do some other projects first, convinced my mentor to let us do a phase 1 trial of the drug my dogs received. It's called piroxicam. So we did a phase 1 trial, dose escalation, because we had no idea how it worked or if it would work. And we learned that, okay, the more you give, the less well they tolerate it. So we established what dose they did feel good on, but we started seeing anti-tumor activity. I mean, not in all of them. I think it may be 20%, but still for a drug that's not a cancer drug. And the dogs that appeared to have the best responses or most consistent were those with bladder cancer. So that sent us down the bladder cancer pathway. So then our follow-up studies were in bladder cancer. And then we began to learn more about the disease, learned that, there's a huge need for that disease. It's a lot better now than it was back then, but still we had a need. This is where I talked about being a clinician and seeing what the needs are. So we knew we had a need. We knew that we thought we could find similarities between dog and human bladder cancer, and we did. It's similar to what's called muscle invasive bladder cancer in people, which is high grade invasive cancer. And so now we have a disease where we can not only help dogs, but we can learn something that might help people. So it was almost an accident that I got into the bladder cancer field. But now we keep building on that because there's so many different angles we can take in that research that we've just stuck with it.
That's a great story, and interesting that you got that regression with a non-steroidal anti-inflammatory. Is Proxicam, just a quick question, is Proxicam part of the protocol for like a gold standard treatment for bladder cancer in dogs typically?
It is.
Okay.
Not that specific drug, but other drugs in that class have become part of what you'd consider standard of care in most dogs. And there are some instances where we don't use it if we don't think it's going to be tolerated, or if it isn't tolerated. There are some other treatments we've tested in the absence of those drugs because we wanted to figure out if those treatments were really working or not. One of them being the study that Puppy Up funded. In that study, for a period of time, they were not on a non-steroidal because if they were, we wouldn't have been able to figure out how well the study drug was working. So, and interestingly enough, so the non-steroidals have single agent activity and they enhance the activity of chemotherapy. They enhance the remission rate. But interestingly enough, there is some growing data that the dogs that live the longest are those that get chemo alone and then later get the non-steroidal alone. And so I don't know that they always have to be given up front to every dog. Most of the time they are, because most of the time we give 2 drugs together to try to get shrink as soon as possible to try to relieve clinical signs.
What's the prevailing theory or explanation for that?
For how they work, how they have anti-tumor activity, or why sequential works better?
Why it's better that you give NSAIDs for a period of time after the chemo? What's the theory?
I only have a very unproven theory, but
Okay, I'd love to hear it.
I can
Absolutely.
give you my unproven theory.
Okay.
We're learning more and more and more that everything we do in oncology has something to do with the immune response to the cancer. And like chemotherapy, one of the major things we think it does is to kill tumor cells, release foreign proteins we call neoantigens, which then stimulates the immune system to come in and attack it. So our theory is that chemotherapy would release those neoantigens, and then we know that the nonsteroidals are immunomodulators. And so then they're coming in at the time they're needed to gear up the immune system to then respond to the cancer. But I want to say that is totally non-proven. That's our working hypothesis. But and at the beginning of the show, I said, we have to follow science. And now I'm telling you something, I don't have science to back me up.
But you might one day.
But we have the science, we know what the drugs do. Now we're trying to figure out how do they do it.
Right, but one of the things I was going to say earlier, but I didn't want to go down this rabbit hole, but it's absolutely true. But because we don't have enough funding available for even the studies that we like to do right now, there's no funding for that. There's no funding to test out that theory right now. Right. And so for me, it's for us as a pet parent, I'd rather get that hypothesis right now. I'd rather get that data right now, right, rather than wait until downstream 5 or 10 years right. from now when you get funding to prove exactly. it out. I'd at least like to hear that as a theory, I guess is what I'm saying.
Sure. So I'm happy to share my theory.
That's why I love this idea about the NIH Canine Data Commons, whatever. Right. I'm horrible with those names, but I wrote it down. So that's an interesting theory. I definitely want to spend some time noodling about it, but I don't want to go down that because that's a very technical conversation. Let's back it up a little bit and start out with, how common is bladder cancer in dogs? Just generally, how common is it?
Compared to other cancers, it's not.
Okay.
So of all canine cancers, it only makes up 1% to 2%.
Wow.
That doesn't sound like very much, but if there really are 4 million new cancer cases in dogs a year, what has been estimated by the National Cancer Institute, then if there are 4 million cases, and even if only 1% to 2% of those are bladder cancer, you still have, I can't do math in my head all of a sudden. What's that? 40,000 or more cases a year. So I mean, there's lots of it out there.
It's a very large population. Absolutely. It is. And I think the number that we use, and I think the number a lot of people are using now, at least in the public, is 6 million new cases of cancer.
I've heard that one too. Yeah.
So
I'm not sure which one to use. But
it's underreported, and it's important for the audience to know, because I always get this question when I'm interviewed by people or just talking to pet parents, is how big of a problem cancer is in dogs. We don't know how many new cases a year. We don't have the data points because there's no way we survey that entire population. But going forward with VCA now only 25% of the veterinarian market, we should have more sizable data where we should have a better idea. But 6 million, 1% to 2% of 6 million is still a big number.
60,000, yeah.
Yeah, absolutely. And I would imagine a lot of those don't go untreated. Do we have any idea, or do we do estimates of how many cases of canine bladder cancer are treated a year? Do we know that?
I don't think we know that.
Okay, we don't even know that data.
I don't know that. Yeah,
that's another one on the challenges.
Right, we can add it to the to-do list. Yeah,
to the to-do list. Absolutely.
That's the kind of information I'd love to be able to look up. That would just how many, and it just doesn't seem like there's a really good place where all that information is kept. But maybe one day.
Yep.
Okay, so next question is, which breeds are mostly affected by bladder cancer?
In our caseload, about a third of the dogs are in what we call high-risk breeds, and those would be Scotties, Westies, Shelties, and Beagles. And then probably breeds related to those, like we see a fair number of, I mentioned Westies, right? Like we see a fair number of Yorkies, and so I think related breeds are probably at risk too, but the 4 that always stand out are Scotties, Westies, Shelties, and Beagles. So in our caseload, 2/3 of our caseload is made up of everything. It could be anything. Like, I don't think there's a breed that's totally protected. There definitely is the breed predisposition in those 4 breeds, and probably more.
Do we have any idea? And if you have theories, love to hear those, throw them out. Why is it that cancer is particularly unkind to the bladders of those high risk breeds?
We're reasonably sure that they inherit something that increases their risk. But what we don't know yet is what it is that they inherit. We don't know, is it something that makes them more susceptible to carcinogens? Is it something that already has led to a precancerous state? We don't know yet what it is, but I can't imagine that there's not a genetic inherited component to it. I mean, there just has to be.
Absolutely. Well, statistics prove it
Right.
out pretty much. So,
right.
But we don't
And that's
know.
where I thought if I got all mixed breed dogs, I would be good, because they weren't breed specific. But yeah, no.
Well, you might be good.
My theory did not follow through. Yeah.
Yeah.
No.
Yeah, I know. And yeah, I wish it would.
So do we know any of are there any genetic markers that we know of with bladder cancer in those breeds? Have we mapped out any of that yet?
So they're not any that we know of yet that you would detect in the bloodstream, which would mean that they have it because they inherited it. So we don't yet know what the inherited markers are. We know that when the tumor forms, it's common to have an acquired mutation in a gene called the BRAF gene. They're not born with it, but in more than 80% of dog bladder cancer, the BRAF gene is mutated. And that same gene is mutated in 8% of all human cancer across cancer types. Not so much in bladder, occasionally in bladder, but more in metastatic melanoma and some thyroids and some colon tumors. And that actually is what we studied in the Puppy Up funded study that we did. It was a drug that targets the BRAF gene.
Right.
And yeah. So yes.
Absolutely.
You're probably leading this there.
Yeah, we'll get to that in a second. But so you said that with the BRAF gene, the dogs it's not present at birth.
Right.
But it is a cancer. So how does it emerge? Do we have any idea how it?
We are dying to find that out.
Do we have a pathway to trying to understand that, or is there some pathway to how we could discover that?
Well, there are multiple things going on that I know of. We've worked with a group at NCI that are trying to map out the inherited traits or the inherited variants. That work is ongoing. We hope to look at some of the samples from the dogs that were in our screening study that did or did not develop cancer to see if we can tease anything else out. There are other labs across the country studying BRAF. Matthew Breen's lab at NC State's doing a lot of work on that. So things are in motion, but I don't know what results we'll get and how quickly we'll get them.
Absolutely. Okay, on to the next question. Where typically does bladder cancer metastasize? How does it spread? How does it, I guess, talk as much about the cancer as said. How does it present itself, and then how does it spread?
It usually presents itself, or we see dogs that come in because they are having accidents in the house, blood in the urine. Sometimes they strain when they urinate multiple times, ask their owners to let them out at night. Those are the classic symptoms. And I use the word symptoms because that's what people understand. And vet med, we're supposed to call it clinical signs, but humor me and I'll call it symptoms. So but those same symptoms are what you'll see with a urinary tract infection. So if you see those signs in your dog, don't all of a sudden think, oh my gosh, my dog has bladder cancer. First, go find the infection, treat the infection, And if it doesn't go away or it keeps coming back, then you look for something more complicated like stones or tumors or something else. So when we see dogs that walk in our door because they have that, most of the time it hasn't yet spread, but in the dogs between diagnosis and death, it will spread to distant sites in the body in 50 to 60% of them. It goes to lymph nodes, it goes to the lung, it goes to the liver, a spleen, it can go anywhere it wants to. But the most common sites would be nodes, liver, and lung.
What is, I guess, what is the gold standard of treatment in bladder cancer? Moving on to that, how do so what would be like, let's start off with the gold standard of treatment. Let's start there and work our way down to how not only how we're currently treating bladder cancer, and then we'll talk about outcomes.
Okay. So bladder cancer is like any other cancer we see as veterinary oncologists. We ask ourselves the question, what is it? And then we, get a biopsy, find that out. How far is it spread? And then if we can get it out surgically, we do that. Most of the time in bladder cancer, we can't, because it's in the neck of the bladder where the ureters come in, the urethra exits, and that's just not an area that's conducive to surgery, with the exception of some exploratory work going on in a few places. And so then we ask, can we treat with radiation? And yes, it can be treated with radiation. It's a bit challenging because the bladder doesn't stay the same shape, size, and position in the abdomen. So it's not the easiest thing, but can be done. Most dogs with bladder cancer get drugs. And we usually think of two broad drug approaches. One is to do a palliative approach with an NSAID. The other is to do an NSAID and chemotherapy. And the NSAID chemotherapy is more likely to cause remission. It's associated with longer survival. It's one where you expect more benefit and relief of symptoms. And if the dog is about to have obstruction or is already partially obstructed, you want to shrink the tumor, so we do chemo NSAID. Whereas if it's the owner wants a conservative approach, something less expensive, less involved, and the cancer isn't about to become life-threatening, then many owners will opt to do a single agent NSAID, and there's nothing wrong with that. So there's really no one gold standard, which I actually like, because that gives us the leeway to begin to personalize care. Like, we don't feel like we're locked in that every single dog has to get X, Y, and Z. We look at the dog and its cancer and its owner, and then try to come up with what we think is the best option for that situation.
Do we? Absolutely. What type of outcome is the typical bladder cancer patient looking at, given the different treatment options?
So what we tell owners is, we think there's an 80% chance that we can buy months to a year or more of good quality life. And if you want to break it down by study, with NSAIDs alone, and that's all you do, the median survival is around 200 days. But there's a whole lot of variability from dog to dog. Some go out years, some go out days, some don't respond at all. And then the median survival with one protocol of chemo NSAIDs about 300 days. The dogs that live the best in our hands are those that start with something, you use it as long as it works, dog feels good, tumor's not growing or ideally shrinking, keep doing that. And then if that's not working, then you do something else, because there are multiple drugs, you can move from one to the other. So when you do that, it's not uncommon to get a year or more of good quality life. But again, I always have to explain to pet owners that I can tell them medians, which they could think of as being an average, but that doesn't mean their dog's going to live that long. There's somewhere around, I hope it's as few as 10%, but I can remember the small number of cases where it seems like the cancer is just going bonkers, and it doesn't pay any attention to anything we do. So those are worst case scenario, and those dogs don't usually live very long, or they're euthanized because their quality of life is plummeting. Whereas they're the exceptional responders that that go out years and would not because of aggressive therapy. They just have sensitive tumors.
Right.
So I can give people numbers, but I have to explain what they mean or don't mean.
Right. Well, I certainly know, and I know Ginger knows that cancer can do the weird things. Cancer
Oh
can
yeah.
go any direction. That cancer can do the unknown. So
Right.
if you think you know cancer, guess again is what
Right.
I'd like to say. Do we? But that's important though, and that's important. I'd like to put that in context for pet parents here because when we think of 1 year for a dog, you think, oh, I've heard some people say, oh, well, it only gives them 1 more year of life, hopefully quality of life. But from what I like to reinforce with our listeners and everyone is that 1 year to a dog that's going to live an average of 8 to 10 years, that's 10% plus of their lifetime. And I don't know about you, but I would do anything to get 10% of more of my life.
Right.
Certainly, the older I get, that becomes
Right.
increasingly
Yeah.
true.
Yep.
So 200 days, 300 days, a year plus,
Yeah.
I think is a positive outcome. As you know, there are some cancers where the outcome is much more dismal
Right.
than that. So bladder cancer, I don't know if this is accurate. Bladder cancer would probably fall under the in terms of outcomes, probably somewhere in the middle, I would
Probably
imagine.
so. Yeah.
Yeah.
And it's
Wow.
better than a lot of other medical diseases. I mean, they're non-cancer conditions that dogs don't live that long with. So,
Yeah.
but it's totally the owner's, it's totally the owner's personal decision on what they want to do, how far they want to go. The people that walk in our door are already those that either already know they want to pursue treatment or they least want to know what's involved. And the people that already know they don't want to pursue treatment, they don't come see us. So
Right.
Right. Yeah, I've found this from my just vast experience talking to pet parents and veterinary oncologists over my travels, is that if they're going to come see the veterinary oncologist, they've already done the numbers, they've already made the decision. It's a commitment,
right.
and I'm sure the numbers will prove that out. But that's why we here on our show we always recommend just to go get that initial visit, the initial consultation with the board certified veterinary oncologist, just to find out what the treatment options are available and the cost, because my guess is also bladder cancer is not one of the more expensive cancers to have. Is that accurate, or would you not know about the retail cost of treatment? I know some vets don't.
I would say, I mean, I'm just comparing it to like the dogs we see with lymphoma. I think it's if an owner opts for chemo NSAID and they live a year, it's probably more expensive than lymphoma, probably. But it really depends on the treatment.
Absolutely.
Like you can get as involved and as expensive as you want to or not. So
Right.
but I'm with you. If my dog had a serious medical problem, for me personally, I would want to know what it is, what the outlook is, and what the options are, and then I can decide, am I going to pursue something or not? And
Right.
there are a lot of scenarios where it might not be best to pursue something, and we always try to make people comfortable that we'll tell them what the options are and help them do whichever option they want to do. But it's really their decision.
Well, it's important to note that there are so many financial resources out there available to pet parents with the cost of cancer. And we're launching Hudson's Hope Fund as well to be another one of the many tools out there. It's important that just get the initial consult, because as you said, even with an NSAID now, you can get a considerably long,
Right.
a good outcome with your companion animal, with your
Right.
fuzzy butt, and have quality of life as well. Do we know, Dr. Knapp, do we have an idea of the average age typically, if you had to look at the entire population, the dogs are diagnosed with cancer? Do we see any of them really, really young, or are they typically more into the geriatric dogs? When do we see bladder cancer?
With bladder cancer, it's usually the older dogs. It's usually 9, 10, 11, 12. We've seen it as young as maybe 4. I don't remember the record, but it occasionally happens in young dogs. If it happens in a puppy or a really young dog, it's probably a different kind of cancer than the traditional urothelial carcinoma that we see. There's one called rhabdomyosarcomas that can affect puppies and young dogs. But for the urothelial carcinoma, which is the same thing as transitional cell carcinoma or TCC, it's all the same thing. That's usually older dogs and occasionally middle age.
Well, I forgot to ask this. This is where I got stuck earlier. Is the urethral carcinoma? What percentage of bladder cancers does that represent?
Probably 90% or more.
A lot of them. Okay.
Yeah.
So if you're going to see bladder cancer,
That's probably what you're going to see.
Got it.
And we used to think they were all high grade. Well, the majority, but they're not. Occasionally we see some that aren't. In fact, I'm trying to remember the numbers in our screening study. I better not try to recite numbers because I don't have them memorized. But there were a few dogs that had low grade tumors, and we were a bit surprised by that. But it's nice to know it happens because that would carry a better prognosis.
Before we move on to the Puppy Up study and some of your other areas of research and interest, what do you have any final words for the pet parent that gets the diagnosis that your dog has bladder cancer for the first time? Just any final thoughts or things I left out?
I like to use the word it's treatable, but I also hesitate because many people think the word treatable means curable. So I guess, my final thought would be it's something that it's likely that it can be controlled with good quality of life, to buy the dog some good time with the family. And so it's when I first started working in the bladder cancer field, we didn't know anything that worked. And at that time, a lot of dogs had a diagnosis made and owners put them to sleep because they didn't want them to suffer. And now that's another thing we realize, well, shoot, even if we don't do anything, some of them are going to do pretty good for a while. So, I would say just try not to let it totally devastate you and make you think you're going to lose your dog tomorrow. With that, it's pretty rare that happens. So, I think it's, something we can deal with.
I just thought of one more question listening to you that I had, maybe the audience would have as well, is that the cancer that when the dog does pass from bladder cancer, is that from the primary tumor, or is it because it metastasized and from the secondary tumor side?
At the moment, it's mostly from the primary tumor causing blockage of the flow of urine.
Okay.
As we're getting better at controlling the primary tumor, there are more dogs that are succumbing to metastasis. But right now, most of them still succumb from the primary tumor.
What percentage? I didn't mean to interrupt you. My apologies.
Okay.
What percentage of bladder tumors are non-excisable? It cannot be surgically removed. Is it the majority of them?
The vast majority cannot be removed.
So the medical oncologist becomes the primary,
right.
The go-to person in the case of bladder cancer. Great. That's all great. I wanted to do a show for almost entirely about bladder cancer. This is exactly what I wanted, but we're running a little bit long, and I wanted to talk briefly about the Puppy Up study.
Sure.
We were very honored. Ginger, please go ahead.
Sure.
Tell us about the study and how it worked and the outcomes.
Ginger cut the check. I thought she could give you the intro and
absolutely. The Puppy Up study that we did was to study a drug called vemurafenib, and you can call it VIM for short, in dogs with bladder cancer. VIM will kill tumor cells that have the BRAF mutation that I spoke about. And there were several driving forces behind the study. We wanted to know if VIM would help dogs, because we knew dogs have the mutation and it would make sense that VIM would help dogs. The second thing we wanted to know was if VIM did not work, or if it worked for a while and then it failed, what were the mechanisms that caused the drug to fail? We wanted to know that information because that could help with human cancer patients. Because human cancer patients that receive VIM or another drug in that class often have a dramatic remission of their cancer, but over time, the cancer gets resistant. And so one of our goals was try to determine what causes the resistance and how do you get around it. And then the other things linked to this was we needed to to figure out what would be the optimal dose of Vim in dogs. What would be side effects that we need to watch for to be sure that we could take care of that. And so the study ended up being, I think, far more insightful than we even thought it would be. So we ended up treating, I think it was 34 dogs. In the initial dogs, we did escalate the dose to try to establish what we call the maximum tolerated dose, which would be the dose at which we would ideally see anti-cancer effects, but they would still feel okay. So we determined what the maximum tolerated dose was, which was interesting, only half of what is considered tolerable in lab dogs. And I think, maybe pet dogs in this scenario don't handle it as well. But anyway, we figured out what that dose was. And then from then on, we gave that dose consistently for the rest of the trial. We did learn that in individual dogs, we would have to frequently tweak the dose. The main side effect that we saw was loss of appetite. And so there were several dogs even treated with what we thought was going to be the optimal dose, where we had to reduce the dose some more. But when we did, then their appetites returned. So we did learn what dose to give. We learned that we see increase in liver enzymes and blood work, and that those are pretty consistent, but don't appear to cause harm to the liver, which is an important thing. And the only other common, it wasn't that common, I think it was in 15-20% of the dogs, side effects we saw was actually this paradoxical development of skin tumors. And this happens in people that get those drugs. And the underlying mechanism is thought if you already have a RAS mutation and you take this drug, you could get skin tumors. And so they were not that troubling to the dog. And, we could take them off if we needed to. And it sort of gave us, it gave us a little bit of confidence that our drug was doing what it was supposed to do, that we were getting effective levels. And so, in fact, when we measured, we did pharmacokinetics, and we knew what levels we achieved, and we knew if those levels would kill dog tumor cells in dishes, and they did. So then there were two remarkable things beyond that. One is the anti-tumor effects, which we were seeing in around 40% of dogs. This is a single agent oral therapy, not with an NSAID, and that remission rate exceeds anything we've seen for a true single agent. And so that was really exciting. And then the other thing that was really exciting was that we performed cystoscopy, and we got tumor samples before treatment, and then a month into treatment, and then when they relapsed. And we expected to see changes in cancer signaling pathways. Well, we did, but those were all over the board. But the most consistent change was an enhanced immune attack at 1 month and immune failure at relapse, which indicates that one of the mechanisms involved in the activity of these drugs is what it does to the immune system. So, the study was highly successful. We have, several other pieces of data I won't go into. The only part that I'm still sad about is that this drug is prohibitively expensive. So I don't think it's going to be used until there's some more costly form of it. It's one of those drugs in people that cost in the tens of thousands of dollars a year, and we can't get it any cheaper. So it's been.
Did Vim perform better than drugs in the same class? Is that what you're saying? The conclusion of your study, or at least comparable, if not better?
Vim performed better than cisplatin, carboplatin, vinblastine, mitoxantrone, and NSAIDs.
And how much more expensive, if you had to say 2 times or 5 times? You had a ballpark, since you're saying you're bringing cost into it, which, as you and I both know, cost is a very important factor when it comes.
I would say it's 8 to 10 times more expensive than chemotherapy. So, and again, I want to emphasize the true single agent, because if you added an NSAID to this, who knows, maybe it would work better.
Right.
But when we give chemo in NSAIDs, and what our favorite protocol is, we have a remission. We have 55 to 60% of dogs have remission. So that is better, but you're going down the pathway of IV treatments. It's a different commitment than giving pills at home.
Are you studying them with an NSAID now? Just to
Not yet. Nope. It's also on the to-do list.
That's a future project, research
Yep.
project. Maybe you can talk to the foundation and see if we'll fund that study as well.
Okay.
Because
All
we
right.
certainly love the research that you've done thus far, Dr. Knapp. You're just, I love our conversations. I can nerd out and talk about science to the depth to which I can, which is not at your level by any
I
stretch.
wanted to be,
Please.
sorry to interrupt you, Luke, but
Right
sometimes
ahead.
if I don't just jump in, I'll forget what I was going to ask. But I just wanted to be clear that the dogs in the study that Puppy Up funded, those were pet animals, correct? They had owners. Okay.
Yep. They're
Just-
pet dogs. We do not induce cancer. They came in because they already have cancer. They were ones where we would talk to the family and offer the option of being treated as part of a study or not as part of a study. Some of those dogs, I'm pretty sure, had already failed other drugs. I'm almost positive of that. But yeah, they're pet dogs, and
Okay.
But yeah, as we all know, there's big enough available population of dogs with cancer that we don't have to induce the cancers that we need to study.
right.
At least.
Right.
How speaking of dogs in the study, how big was the population? What was that in?
34.
34. That's a pretty good sized study. 34.
It's okay. I mean, it's for vet oncology. Yeah,
For
that's
vet
a
oncology,
yeah.
veterinary oncology, it's a good number, but
Yeah.
the number needs to be up over 100 because, my second dog that got cancer was nasal adenocarcinoma. We wanted to see what the effects of follow-on chemo after radiation, and the only study available that Steve Withrow could find was out of Australia, and it was 8 dogs. And it's like,
Right.
well, what scientifically or medically
Right.
can we know about that? We did it anyway, and it was probably not a good decision. And I mistake. I make so many. I made so many mistakes on my dogs with cancer.
Well, this is. I don't want to get off on too much of a tangent, but for you and for the other people listening, all we can do when we're in a scenario treating our dog is make the best decision we can with the info we have at the time. And that's what we can do, and that's what we should do. And sometimes things go really well and sometimes they don't. And when they don't, it's not because we made a poor decision. It's just because that tumor didn't respond as we had hoped it would to that treatment. And so I'm not trying to in any way diminish your thoughts, because we all have them. We all say, well, geez,
I have them every day. Unfortunately, I'm Sisyphus rolling. I'm that guy that I really do bears hard on my soul the mistakes that I've made, but it's not a healthy thing to do. And again, it won't change the outcome. Hudson was one of the most recent ones, but I won't go into that. But I did want, before we leave this topic, I did want to ask one other question. Ginger made a good point that Puppy Up Foundation only funds clinical trials on dogs that already have cancer. I did want to ask a question about the skin tumors, though. Those were benign, correct? Right. Not malignant. I think that's an important distinction that needs to be made. Do we know how that? I think you said it was. We see that in humans, but do we know the pathway that causes that, or that's still under study?
I think it's under study, but in humans, the prevailing theory is that if the person already has a mutation in a gene called RAS, that can lead to cancer signaling that leads to the development of these skin tumors. So
long as they're benign,
they have some clues.
Good to know. But so long as they're benign, we could just pull the suckers off. All right. What are some areas? We're running long here. We try to keep it to an hour, but you've got so much great data information. Before we kind of wrap things up, Dr. Knapp, I want to give you the opportunity to talk about, are there any other areas of research or things that you're interested in you'd also like to talk about to our audience?
I think, the research is just exploding, and I've got to go in actually a couple of minutes too, but the research is just exploding on many fronts. And we make a research map of what do we, how do we organize what we do? And in our map, we have a box for prevention. So prevention could be early detection. It could be thinking of things that might prevent the cancer. And then we have a box for how do we make the best use of the drugs we already have in our hands? And that could be different schedules, different combinations, drugs that might have been developed for one purpose, like the NSAIDs that now help with something else. And then we have a box for new drugs, and that would include immunotherapies and targeted agents. And then we have a box for individualizing care, and that is, what can we learn about the cancer so that we know what treatment will work best in the individual rather than lumping all the animals into groups. And then we have the box for translation, and what can we learn from dogs that'll help people. So that's the generic answer to your question. But there's just so much going on, so much excitement, so many opportunities that I've been doing this for a little while. I still like getting up and coming to work every day.
Absolutely. There are a lot of exciting things, and you're definitely a friend of the Fuzzybutts, and you're always welcome back on our show to talk about anything, new areas that you're excited about and new things that you're doing. And we will certainly follow up about the potential about doing a cocktail study with that VIM and an NSAID to see if we can get those numbers up. I don't know how we can get those dollar amounts down. That would be an entire discussion, but 8 to 10 times more expensive than the current standard of care is substantial. So, Ginger, as we wrap things up, did I screw anything up? Did I miss anything? I know we usually do at this time a Puppy Up Foundation cancer tip of the week, but this episode has pretty much been entirely about bladder cancer. So, Ginger, anything else I need to? I've messed up on my end.
No, I don't think so. I think we pretty much covered everything. I just want to thank Dr. Knapp for being on the show.
Oh, thank you, Luke and Ginger.
Absolutely. Well, thank you for doing such a wonderful job on the study, and you provided us with all the data that we needed. And I did forget to ask you is that, and I think this is important as a pet parent, is the data that from the study, is it going to be published? What's next with that? Because I want to make sure that somewhere gets in the public domain out there.
So the VIM study has been published, and actually it's now in the NCI's Integrated Canine Data Commons.
Ginger, did I not get? I don't remember getting this email, Ginger.
I sent it to you. You don't.
Oh my goodness!
I sent it.
I should have known that answer before I asked the question, like any good lawyer, even though I'm not, because now I look like a complete moron, which I am. So I will. That's very exciting. Congratulations. I think that's so important that the data gets published, and I'm going to go to this Data Commons website and look for it.
Yeah.
And we'll make sure that we'll post the link to this wonderful study that the Puppy Up Foundation funded. We'll post a link to that in our show notes when we drop this episode in a couple of weeks. All right, Dr. Knapp, thank you so much for being a part of Fuzzybutts and Friends. Thank you, Ginger, for being my co-pilot and co-host. Everyone out in our audience, thank you again. Puppy Up. Talk soon.
Puppy Up. Thank you all.
Thank you.
You're welcome.